The next part of midgut, that is the midgut rotation. So we have just finished the physiological herniation, which occurs around 6th week of intrauterine life. So you know, by 6th week the contents, the abdominal contents, to be more precise, the liver will be enlarging and there will not be enough space for the intestinal loops to accommodate within the abdominal cavity. So what happens is these abdominal contents, or these abdominal loops, to be more precise, midgut loop, will herniate out of the abdomen into the extraembryonic coelom, and that is what is termed as physiological umbilical hernia. Fine. Then what happens is, by the end of 3rd month, or to be by 10th week onwards, by 10th week of intrauterine life, these herniated midgut loop will return back into the abdomen. Fine. So as it is returning back, you find a rotation of midgut also. So the purpose of rotation of midgut is to, of course, to get the contents back into the abdomen, plus to assign or to fix the corresponding position for the midgut loops, for the intestine to come and occupy the so and so position as you see in normal adults. For that, the midgut loop undergoes rotation. So when the herniated intestinal loop returns back to the abdominal cavity, you find rotation, and at the end of the 3rd month of intrauterine life. So now what happens? This is the midgut loop, what you see here. This is the midgut loop. This is the midgut loop. Now it has herniated out of the abdominal cavity, and the total rotation for the midgut loop is 270-degree anti-clockwise. That should be there in your mind always. 270-degree anti-clockwise means first 90-degree anti-clockwise, then 90-degree, and then 90-degree anti-clockwise. Fine. So remember that the first 90-degree anti-clockwise rotation will occur outside the abdomen. That is, when the coil is present within the umbilical or in the umbilical cord. So look at that. This is the first rotation that you are expecting. So this is the normal position before rotation. You find the superior mesenteric artery there. This is the cranial limb or pre-arterial limb. This is the post-arterial limb. Now what happens is, this loop within the umbilicus or outside the umbilicus within the extraembryonic coelom will undergo first 90-degree anti-clockwise rotation. So you imagine a loop of wire. In the center you have got the superior mesenteric artery, and if it is rotating 90-degree anti-clockwise, what will happen? This loop, this pre-arterial loop, will come to lie on the right side, and this post-arterial limb will come to lie on the left side. So that is the first 90-degree anti-clockwise rotation. Read that. Initially it was pre-arterial above, post-arterial below, first 90-degree anti-clockwise rotation, the umbilicus, and as a result of it, the pre-arterial comes to lie on the right side and post-arterial comes to lie on the left side. Now what happens is, so we have finished 90-degree anti-clockwise. So next 180-degree anti-clockwise rotation will occur within the abdominal cavity. When this content is herniating back or it is coming back into the abdomen, you find the next 180-degree anti-clockwise. That is how you get initial 90-degree anti-clockwise when it was outside, that is in the umbilicus. As it is returning back, you get the next 180-degree anti-clockwise rotation. So this is the first rotation. First 90-degree anti-clockwise rotation has occurred, and you see this is the pre-arterial segment that is coming and lying on the right side. This is the post-arterial which is lying on the left side. So first 90-degree of rotation is over. Now what happens is, now this is the loop. This is the loop. It has undergone the 90-degree anti-clockwise rotation. Now remaining is 180 degree anti-clockwise rotation. So what happens is this pre-arterial loop returns first, and as it is returning first, you are seeing this uh, anti-clockwise rotation 180 degrees. So what happens is this pre-arterial loop will come to occupy the left side. See, it's coming to occupy the left side, and you find the duodenum will be passing behind the superior mesenteric artery. Fine. So as a result of this 180 degree anti-clockwise rotation, the abdominal contents are returning back. Within the abdominal cavity you find that rotation, and as a result of that, this pre-arterial segment comes and occupy the left position, and the post-arterial bud will come to occupy the right side, and thus these contents get its appropriate position in the abdomen. So that is the purpose of rotation of gut. If you are finding it a bit difficult to imagine things, you can have a wire in your hand. Imagine a wire. In the center of the wire you attach another small thread. Imagine that to be superior mesenteric artery. Just turn it, and then you will understand that the pre-arterial segment is coming and lying on the left side, and then you find the post-arterial is coming and lying on the right side. So you find the reduction of physiological umbilical hernia, that is the return of midgut, occurs in 10th week of intrauterine life. Fine. So now the abdominal contents have returned back after the rotation. Now you should know some more details about caecum and appendix. You know where caecum and appendix is developing from. It is coming from caecal bud. Where you find caecal bud? It is in the post-arterial segment. So what happens is the proximal part of the caecal bud will form caecum, and the distal part will form appendix, and you find some changes occurring in the shape of caecum and appendix. So we shall look at the figure so it will be clear to you. So look at that. This is the caecal bud that you find developing from the post-arterial segment, and then look at that, the caecal bud is increasing in length, and then you find this proximal part of the caecal bud becomes the caecum, and the distal part becomes the appendix. Now you find some variation, or not variation, some changes occurring in the shape of the caecum and appendix. Initially you find it as conical. It will be conical, and then you find the appendix will be attached at the end of it. Now what happens is the caecum now gets a saccular appearance. It will be having right and left saccules. Now what happens is this right saccule will undergo more growth when you compare it with the left saccule, and sometimes right saccule often shows an exaggerated growth also, and as a result of it you find this appendix or appendicular opening coming to lie very close to the ileocecal orifice. So as growth occurs, you find some change in the position of appendix and caecum. Fine. So one more thing is, initially you find the caecum, as a result of the rotation, you find the caecum and the appendix will be very up, very just below the liver. There you won't find a well developed colon, ascending colon. Now what happens, as the growth advances, this caecal bud, the caecum and the appendix will be coming down and occupying the right iliac fossa, thereby producing a well defined ascending colon. Fine? Okay. So these are the different parts, the different types of caecum and appendix. Now what happens? So now the abdominal contents after 270 degree rotation, anti-clockwise rotation, has returned back. The caecal bud forms the caecum and appendix. It is initially was subhepatic, that is just below the liver, and then as it descends down, the ascending colon becomes well formed. Now Fixation of gut is there. What do you mean by fixation is initially the whole of the intestine, the whole of the midgut loop will be attached to the posterior abdominal wall by the mesentery. But later, what happens is the duodenum will lose its mesentery, and then what happens is the mesentery now gets confined from the duodenojejunal flexure, that is the DJ flexure, to the ileocecal junction. So, that part, that is the jejunum and ileum, will have a mesentery. Then, ascending colon will not have a mesentery. What happens initially, even if it has, it undergoes zygosis and then becomes retroperitoneal. Of course, transverse colon, will have a very well defined mesentery. Not you call it as mesentery, it is mesocolon. Fine. It is termed as transverse mesocolon. Sigmoid colon also has got a sigmoid mesocolon. All other parts, that is retroperitoneal, will be that mesentery attached to it will undergo zygosis, and that is how it becomes retroperitoneal. Hope that is clear to you. Fine. So now, or we are going to proceed with the anomalies of midgut. So how far we have reached in normal? 270-degree anti-clockwise rotation, and as a result of that, the contents have returned back and occupying the corresponding position. The cecal bud forming the caecum appendix, initially just below the liver, now descends down, reaches the right iliac fossa, thereby formed a well-defined ascending colon, all parts occupying the corresponding position. Then you find the fixation of the gut occurring, so that certain part will have well-defined mesentery or mesocolon, like jejunum and ileum, sigmoid colon, transverse colon, like that. So now we'll proceed on towards some of the anomalies that you find in relation to midgut. So first one is Omphalocele. So Omphalocele is one of a rare presentation, just 2 or 2.5 in 10,000 births. Such a rare presentation you get for Omphalocele. So what is actually this Omphalocele is the baby born will have this abdominal contents, the midgut loop. The intestinal contents will be herniating out, and it will be covered with a transparent membrane termed as amnion. So that is the presentation you get in Omphalocele. The newborn baby have the gut loops will be herniating out, and it will be covered with amnion. So you have to note that it does not have a covering of skin. It will be just covered with amnion. So what is the embryological cause of this Omphalocele? That is, I've already told you at 6th week you have got physiological umbilical hernia, and by 10th week the contents will return back. But if the contents are not returning back, that is what is termed as Omphalocele. Fine. Now second one, that is a congenital umbilical hernia. So here what happens is it's a herniation occurring through an improperly closed umbilicus. So what happens through that improperly closed umbilicus? This abdominal contents will herniate, this loops will herniate into the through the umbilicus, and it of course will have a covering of peritoneum. Outer to that you find it is covered with skin. Unlike that in the Omphalocele, here it will be very well covered with skin. And here this abdominal contents after physiological hernia, it has undergone reduction, it has come back to the abdomen, but because of some defect in umbilicus it is herniating. That's all. Suppose for the baby cries, when the intra-abdominal pressure increases for crying like that, this contents will protrude out through the umbilicus. So that is what is termed as congenital umbilical hernia. Now, different types of anomalies of vitellointestinal duct also you find. So normally you find what I've already told you. You find the ileal loop. The ileal loop will be attached through the vitellointestinal duct through the yolk sac. And what happens is, I've already mentioned, this vitellointestinal duct will undergo degeneration, or it will undergo fibrosis. But if certain regions of vitellointestinal duct is not fibrosing, it can present with an array of symptoms. So first one that you should remember is Meckel's diverticulum, otherwise termed as ileal diverticulum. What happens is a part of the vitellointestinal duct very close to the ileum will remain as such, and other part undergoes, that is other part attaching to the umbilicus will be fibrosed. So that presents as a diverticulum from the anti-mesenteric border of ileum. Fine. And that is what is termed as Meckel's diverticulum. So this Meckel's diverticulum sometimes can present as ulceration, bleeding, and in certain cases the symptoms of this Meckel's diverticulitis will actually mimic acute appendicitis. Fine. So that is the first presentation, Meckel's diverticulum. Now imagine when the whole of the the what you say whole of the vitellointestinal duct is patent. Look at that, when the whole of the duct is patent, so that one end is attached to the ileum, the other end will be communicating through into the umbilicus. So that is what is termed as a fistula connection, between the ileum and umbilicus. Then what happens is, in certain cases you have got a sinus formation also. In sinus formation, the part of the vitellointestinal duct very close to the umbilicus will be patent, but the rest other part will undergo degeneration. So that is what is termed as sinus. So you can get fistula, sinus, Meckel's diverticulum or ileal diverticulum. In this picture you are seeing the Meckel's diverticulum or ileal diverticulum. Fine. So next is different. I told you have got rotation of the midgut. Any abnormality in the rotation of midgut can also produce different types of presentation. So first is non-rotation. If the rotation has not happened, that is the final 180-degree rotation has not happened, what happens is, you see this is the small intestinal loop. This small intestinal loop will be lying on the right side, and the large intestinal loop is lying on the left side. So that is normal, that is abnormal. That occurs as a result of non-rotation. Next is reversed rotation. Instead of anti-clockwise rotation that is normally happening, here you find if the rotation is occurring clockwise, what will happen? Initially, if the normal rotation was occurring, the duodenum will pass behind the superior mesenteric artery. You find the superior mesenteric artery here, and this is the duodenum. In that case, the duodenum should pass behind the superior mesenteric artery, and transverse colon should lie in front of that. But because of this reversed rotation means anti-clockwise becoming clockwise. So what happens? Behind you find the transverse colon with mesocolon, and in front of that you find the duodenum with superior mesenteric artery. Now subhepatic caecum and appendix. I have already told you here initially after the cecal bud will be lying just below the liver, and then what happens? It descends down and reaches the right iliac fossa so as to form a well-defined position, reaching its definitive position. But in certain cases that descent does not occur, and the caecum and appendix will be still presenting at that region, that is just below the liver, subhepatic. And what happens is, this subhepatic presentation of caecum and appendix, if sometimes appendix gets involved, inflamed, produces symptoms, and it very commonly will mimic a cholecystitis. Cholecystitis means inflammation of gallbladder because of that location. So these are some of the applied aspects that you should remember for caecum and appendix. I think with that we finish the midgut derivatives. Hope it is clear to you now. The rotation of the midgut plus some of the anomalies like Omphalocele. Then what else? then different anomalies of rotation, Meckel's diverticulum, like that, subhepatic caecum and appendix. So I think with that I'll stop the session here, and next session I'll continue with the hindgut derivatives. So okay, thank you.